Welcome to Untamed Blossoms, the podcast where we celebrate the untamed journey of womanhood. Here, we tell the stories of incredible women who have embraced their authenticity, inspiring others to do the same.
From entrepreneurs to artists, activists to adventurers, we share triumphs, challenges, and the beauty of self-discovery. These are the stories of women blazing their own trails, breaking free, and blooming unapologetically.
Join us to connect, be inspired, and celebrate the power of women's stories. Together, let's rewrite the rules and embrace our wildness.
Welcome to Untamed Blossoms. I'm your host, Amanda Riley.
And I'm Christy Riley. Welcome to the show, everybody.
Welcome back to Ohio.
Thank you. Oh my gosh. We went on spring break in Florida, Fort Myers Beach. Never been there before. It
Beautiful.
was fun. Gorgeous. Gorgeous. That island is still not really quite back to pre-hurricane status. So it's really slow, the renovation of the island, but the beach and the water was
Beautiful.
stunning. And, you know,
The weather was good?
Weather was good. We were in the high 70s, low 80s every day. Got chilly at night. Like you kind of needed a jacket, but the girls still wore sundresses and did all of their beachy things. And the water was chilly. Like I would say the water was probably 70-ish degrees, maybe less. But we still swam. We still got in, did some cold plunging, what I consider cold plunging.
It's frozen.
I'm like, oh God, it's so cold. But no, it was good. It was just very chill for us. We didn't do any activities. We told the teenagers, we took just the girls and a friend of theirs. So it was just very chill.
So good. That's what you needed.
That's what we needed. And it was really great. And you know, it reminds me that I should be living on the beach.
I'm going to bring it up, but
my soul is really happy at the beach. Just by the ocean and feet in the sand and mostly barefoot all the time. And I know that you guys can tell, but we're currently barefoot. Like we rarely wear shoes.
Rarely, truly. I didn't get a pedicure though. I noticed that you got one.
No, I didn't get a pedicure. I just painted my toenails. I don't typically during the winter. So even my husband was like, "Ooh, your toes are painted." I'm like, "Is that exciting for you?"
You're like, "Sorry, I've been letting you down this whole time."
Didn't know. He's like, "I love you no matter what." But yeah, he knows.
Yeah.
I did it for vacation.
Yeah.
Sometimes I just do it to be fancy, but typically
I love a fancy vacation pedicure. That's the only time I get them normally is vacation.
Yeah.
But you know, summer, these dogs can't be out here in open-toed anything. So I am going to have to make some choices.
But sun on my face, got a tan. Teenagers burnt themselves. You know, it was a normal spring break spot.
Was it like crazy with spring breakers or anything?
Yeah. Oh, yeah. That island is like, we had to rent bikes because it took you 2 hours to get the 3 miles on the road if you had a car to try to get to where the restaurants were. Because that island is literally, it's a one in, a one out.
Okay.
And so, but mostly you want to get in and out on the one side because that's where you get back to the mainland versus if you leave the south part of the island, you're going to other islands. Yeah. You don't necessarily automatically connect back to the mainland.
Yeah.
So it really, and then there was construction because they're trying to put roundabouts in to make it easier instead of lights. And but that's where all of the entertainment is. That's where all the restaurants are. So that's where all the people that are walking are and pedestrians are. And so you're constantly like, it's like Frogger. You're dodging bikes and kids and people and cars and but taking a bicycle down was beautiful. So I loved riding the bike and getting some exercise. And the last night we were there, it was really windy and the bike ride back was like gale force winds against us. And I was like, are we? And Haley was behind me going, I'm going to have to push my bike. I think I'm not going to make it. It's pitch black. We were laughing our ass. We had a really good time. It was just good family, low-key fun. And the other teenagers got to ride their bikes into town and have some independence without us. It was great.
Wonderful.
Yeah. I felt pretty safe there. I didn't like the kids being out. Like I wouldn't have been okay with them being up there at night.
Yeah.
It's a lot of bars and a lot of, you know, people drinking and looking to hook up and all kinds of things.
Right.
So we let them go up and we were up there until like 10 o'clock at night, which if anybody knows us, late as hail for us. And then we all drove back and they were fine. So,
yeah.
Yeah, they were good.
Well,
they were all
I'm glad you
good.
guys
They
had a
didn't
good
sneak
time.
out. And so some of the things that I was kind of anticipating, like, did you stay in the house the whole time? But they did. I think they were a little nervous. So
that's good.
We had a good time.
Glad you got some sunshine.
Food is gross. You know, it's never great. Like, it was okay. I will say food was just...
The ocean is right there.
Dude, everything is deep fried and
no, you gotta get black and grouper.
We did, and it was still just. There was 2 restaurants we went to that was decent. We had decent food, but at the level the spring breakers show up, right? Like they're so slammed.
Yeah,
that even if you would have gotten good quality food at one point,
yeah,
the chances of that during that volume was pretty slim. As restaurateurs, we understand that in some way. So we ate at home quite a bit. We went out maybe once a day, but even a couple of days, I'm like, we're just going to eat stay, and it's just not worth.
I know.
Plus, the pricing of it is so hyper inflated that you're like, every meal for 5 people is $300, and you're like, well, hell,
the coin,
right?
Or some shitty grouper,
right? Everything should be good if you're going to spend $300 to go out to dinner, and it wasn't great. Then you're like, why did I spend all that money?
When we go to Anna Maria, we always like go to probably 5 places or so while we're there.
Right.
And it's always like Noah and I always talk about this. It's like either the whole vacation you get the best food, or the whole vacation, it's not even you get the worst food, but you pick the wrong thing.
Right.
You know what I mean? Like you're like, oh, this one's really good. I'm going to try these things. And it ends up like being shit and everyone else's food's great. And like, so last trip I had a very solid run of like delicious, solid
great choices.
Noah
did not.
He struck out almost every. He's like, why did I order that? I should have ordered something different. But like, it just happens, I feel like, when you're on those type of vacations.
It's a good, I want to try it.
Yeah, try something different.
And then you try it and you're like, that was a terrible idea.
Why did
I should have stuck to the thing I knew was good on this menu. And again, and then you spend the money and then you're like,
why?
Yeah. Stan always says you just chose incorrectly.
I do feel like he could be right. Because
I got a steak one night and he was like, we're in the middle of seafood. You know, 100% you should only order seafood here.
Yeah.
What are you doing?
Yeah.
And then it was terrible. And he was like, ordered incorrectly.
Like, shut up.
My restaurateur husband. Yeah. He's like, that was your fault.
I will say that was a bold move.
It was a nice restaurant and I like, and it was a filet.
Yeah.
No, it wasn't. And it was gross and had some weird aftertaste flavor on it. And I was like, taste this. And he's like, oh. I was like, yep, can't eat it. I don't know. I don't know what it was, but it had a weird, almost chemical flavor. Like that was the way they cooked it. Like, I don't know.
Pans.
Something. Well, so it was, but vacation was great. Yeah. Thank you. We weren't sure we were going to go. And
I will say
we did.
I'm glad you got some time in the sun.
Yeah.
I didn't like that I got to and you didn't. That made me feel sad.
Color.
You did. You're glowy.
Yeah. Yeah. Excited.
It was also nice though to have a week of break of recording because I did get very caught up. I feel very good going into this week.
Good.
We record 2 a days on Mondays.
Right.
So that does require some things.
Especially from you. You do brunt all of the shouldering of editing. It's a lot more for you, I think.
It's just more so that I think, well, I'm so fast at this now.
Yeah.
Like, it'll be fine. I have time.
Right.
And then my week falls up and I'm like, shit, when am I going to do this? So I'm happy to say that I have edited and made graphics and did promo videos all the way through all of next.
Nice.
All of April.
That's awesome.
It's done.
Done.
So that feels good.
Yeah.
Now we can talk to other fun guests. I'm excited for today.
Yeah.
Before we do that, I do want everyone to know I did not have a mental breakdown. That's not why I have bangs.
I love your new haircut, by the way. We have not talked about it, but I didn't see it down at the gym today, but it was so cute.
2.5 years ago, specifically, chopped off all my hair and had a huge mental breakdown about it. Like, I was like, why did I do this? Like, it was a huge mistake. And I really, anyone that was around me during that time, I'm so sorry. I really, really melted down about it.
So because you hated the cut? Like once it was done?
I mean, it was just a little shorter than it is right now, a little bit. But I just thought I looked horrible with it. So I have recently been noticing, because I've been braiding my hair a lot to just get out of my face, right? My braid is so tiny. But like my hair up here was like thicker, like above my ears.
Yeah.
And I was just looking at it. I'm like, man, it just grew in different speeds. And I have been doing a lot of healthy things to my body. And I feel like I started growing more hair back. I had lost a lot of hair from years and years and years ago of doing some extreme dieting. So I had lost a ton of hair.
Yeah.
And I think it's starting to like finally start to grow back.
Yeah.
And it just was like looking a little crazy too. And I was like, okay, I'm going to cut this, but I can't do to everyone what I did. You know what I mean? Like I can't do
freak out.
Again. So I'm like, I have to make a different choice somehow.
Yeah.
And thanks to artificial intelligence, which I do like to use only sparingly because it does cost a lot of water for those things.
You put your photo in and it gave you a bunch of different options.
And it gave me a bang in one of them. And I said, you know what? I can do a bang. I've done a bang before.
I think it's adorable. Yeah. I think you look great. I love the haircut. I can't wait to see it all the way down.
It's giving, I'm a little lad who likes berries and cream when it's all the way down. Like it's a little, it's just not nearly as cute when it's just like down and straight. So I would always either put it half up or, throw some curls in it. It's still a lot easier than what it was before.
Yeah.
So.
Yeah. You ended up with it up in your braid anyway. Even if you wore it down, it ended up in your braid pretty.
Always. Almost immediately.
Yeah. Within a couple of hours. You're like, I'm going to braid it off to the side.
Yeah. Just get it out of the way. So anywho, I just want everyone to know. Adorable. I know when you see bangs, you first think, I mean, I don't want to say I didn't also have a rough go. It was Mercury retrograde and it's eclipse season.
For reals.
And I've been having some weird things happening to my body. But none of that was a triggering cause. I want to make that clear.
Yes. It was not a contributing factor.
No. And I've been sitting on this choice. I had a gift card. Right. So I've been sitting on this choice for months.
Right. You made a really educated, thought out, prepared, AI validated choice.
Correct. This was not a retrograde situation. I just want to make that clear. So if you're watching on YouTube.
Into all kinds of new things though. This is all new and fast and the energy that's coming is for reals. And this last week was nuts. And so
bonkers.
I'm sure that you felt it in every way too. Yeah. So those of us who are sensitive to this is like, what a roller coaster we're on.
This is wild.
Hey. So yeah.
What a time to be alive. Yeah. Truly.
Yeah. But speaking of physical things happening to your body, our guest today has a clinic here in town.
Dr. Alexander-Martin will be on the pod today.
Yes. She's going to join us shortly.
Yeah.
And offering all kinds of cool things that I think that is really necessary in today's world.
Totally.
And I can't wait to hear her point of view. But from a personal standpoint, I would love to hear her talk about hormone replacement, all things menopause, perimenopause. But also she treats people with all kinds of issues, thyroid issues,
addiction,
low testosterone addiction. Yeah. She does some sort of aesthetic treatments as well. So quite the plethora, medical weight loss, like all kinds of stuff, which I think is mostly related to hormones is what I think she's going to say. So
for sure.
I think she's going to be a wealth of knowledge and I can't wait to talk to her.
Same. All right. Hello. Welcome, Dr. Alexander-Martin. How are you?
Hello. I am excited to be here today. Just got back from spring break and excited to be back in Ohio.
Where did you go?
Went to Orlando.
Yeah, we were in Florida too. We were just talking about that in the intro. We were down at Fort Myers Beach.
Okay.
So, yeah. Did you take the kids?
We did.
Yeah.
We got in late. Our flight, we were on the tarmac for 2 hours.
Oh, gosh. Oh my gosh.
A whole bunch of people were trying to leave at once. And so we got delayed and it was a storm.
Yes.
So they were serving water on ground, trying to keep us entertained.
Oh my gosh.
We just had this conversation on our way back and I had it with my son-in-law. He was like, I think I'd rather fly with the littles. And he was going to Myrtle Beach. And I was like, yeah, but you could drive there pretty easily. And he's like, it's so much faster. And I'm like, maybe not. When you leave 2 hours early, then you sit on the tarmac and you never know, right? Like something like that can happen. And suddenly you're kind of at the same timetable to get there as if you had driven.
Especially Myrtle Beach.
Yeah. And like, it's really not that big of a deal to drive, but we drove to Fort Myers, which is a 20-hour drive. We normally break it up in 2 days, but I was like, sometimes you just don't know. We traveled to a flight a couple of years ago that was a nightmare. We were going to Colorado over break on Christmas. It was like a 36-hour ordeal. It was terrible.
Wow.
Yeah. But that whole trip ended up being a nightmare.
I love the old joke about like Midwesterners are so ready like to get in a car and just like, oh, it's only 20 hours. It's like not a big deal.
Not a big deal. We'll drive it.
Yeah. I could do 8. But going that far in Florida, we were ready to go and just hit the airplane and lift off. We want to lift off. We got in at about 10:30 last night. So
wow, it's a quick turnaround. Well, thank you for coming here to the studio today
after spring break.
Yeah,
excited. Awesome.
Now, did you grow up in Ohio, or where did you grow up? Okay,
so I grew up here in Central Ohio. I'm a graduate from the Worthington High School.
Nice.
They were split, and I'm a graduate from the Ohio State University.
Awesome.
And then I went to medical school in Cincinnati. So
wow,
I've pretty much been here the whole time.
Yeah, you're a true Ohioan. Through and through.
Buckeye went to the national championship earlier this year. Definitely a Buckeye.
Oh, love that. And did you have multiple siblings? Were you an only child?
So I'm the oldest.
Oh, okay.
And so I have, how to describe? I have one full blood sibling, my sister. I have a half brother. I have a half sister, and I have a step brother in there. So between two different families, I grew up with the oldest of all.
Got you.
Somehow I sensed that.
Yeah.
But then,
Me too. Me too.
Motivated.
You have an oldest sibling energy about you.
Yeah. Syndrome.
Do you dabble in astrology at all? Do you know your sign? Okay.
I mean, I know I'm a Leo, but I don't.
You're a Leo.
Leo
queen. Nice.
I'm a leader. I know that.
Yeah.
And my mom's claim to fame is I have the same birthday as Barack Obama, August 4th. Different year, though. Different year.
I think so. Brock is a Leo sun and he's a Gemini moon. And so am I. And so I also am always like, I have the same energy as Barack Obama.
But he's August 4th. So
you're right. You're right. I just always in my head, I'm like, we're the same.
We're the same.
But you're even closer. So I'm quite jealous. He's my role model in life.
So where did you go after medical school? What part of medicine did you land yourself in?
So by training, I'm a family physician.
Okay.
And I enjoyed doing that. I know at one point I wanted to be a pediatrician. And I actually went into medical school thinking I was going to be a pediatrician. But there were some instances where I said, you know what, I think I want to do family medicine instead. Just because, true stories, I would see children who didn't get what I would have wanted to give them as a parent. And, for instance, I'm also a pharmacist, because I'm a glutton for punishment. I don't do enough. But I remember being in a pharmacy and seeing a woman come in with a prescription for an antihistamine because her child was having an allergic reaction. And her insurance wouldn't pay for the generic. They would only pay for the brand. But we didn't have the brand in stock. So instead of spending $3 on the brand for her daughter, she decided to wait until $3 for the generic. She decided to wait until we got the brand to leave her daughter suffering, but she's walking out with cat food. And I just thought, you're going to spend money on cat food, but you won't spend money on medicine for your daughter who's having an allergic reaction because you want to get it for free. And that just didn't sit right with me as in the pharmacy. And so there were just enough situations where, sometimes with parents, it's why are you not thinking about your children?
Right.
I remember having a stepdad who would smoke. Why are you smoking around me?
Yeah.
Get that away from me. But so it was this sense of adequacy of children and the environment that they're in. And are the parents really looking at what's in the best interest of the children? Or are they being, if I say, selfish? So anyway,
not aware really. My 30 years in pediatrics is I think they're not being selfish as much. They're just really, truly unaware.
And that could be, that could be.
There's some selfishness in there too. I can't negate that. We saw some really terrible things, but I just think people are not aware of themselves.
Yeah. But there are just enough of those that just kind of set me like, maybe I want to do family medicine so I can still take care of children, but get to take care of adults as well.
Right. Conversation as a unit. I mean, I know you would still do that as a pediatric caretaker, but being able to like me as like seeing the whole family picture and dynamic, I would imagine would be very helpful.
Yeah. And being able to give advice and what you see and then, help people grow. So, but that was where I started then in family medicine. So I did my residency in family medicine, which I enjoyed. And I worked for 5 years as a family physician. And that was pretty much what I did until I needed to quit my job. And I had to quit my job for lack of a better reason because I was not getting enough hours. There were too many holes in my schedule. And so I wanted to work part-time in the office and then work part-time as a pharmacist, but doing something different to try to make ends meet. And initially they said I could work part-time, but then they changed their mind and said, no, you can't work part-time. And said, so what are you going to do about it? Like, well, you leave me no choice but to quit and find something else because right now ends aren't being made. So I started to work with a friend who taught me how to run my own business, and he focused more on addiction medicine. And so we take care of a lot of patients with opiate use disorder, alcohol use disorder, and letting people know that there's treatment and there's hope and you can recover and live a normal life. And that's really, really exciting to help people in that way. But at the same time, I had also received something in the mail from the Center for Medical Weight Loss asking if I wanted to be a Center for Medical Weight Loss. And initially my friend, he was doing kind of some medical weight loss. So it was more just giving a pill, but that's what he did. We said, well, let's go ahead and meet, get some information. And he forgot about the meeting though. So I went through with the meeting and I was very intrigued about, wow, prevention. I can help lower type 2 diabetes, lower high blood pressure, lower high cholesterol. It's a different kind of medicine. It's a prevention rather than waiting until someone gets the problem, then trying to deal with it. Yeah. And that's really what piqued my interest because my philosophy is an ounce of prevention is worth a pound of cure. Right. What can I do now to prevent a problem later? Yeah. So I pursued becoming a Center for Medical Weight Loss and eventually got board certified as an obesity medicine physician, in addition to being board certified as an addictionologist, and opened my own business where I've been since 2009.
Wow. That's incredible.
Let's talk about addiction.
Yeah, I was like, I have so many questions.
So many questions. Yeah, let's talk about that.
And addiction, I would like to talk about both sides there, right? Like the weight loss stuff and what you're seeing with that. And, as someone who's definitely struggled with a ton of weight gain and loss back and forth throughout my life, and then knowing people very close to me that have struggled with opioid addiction and myself getting sober from alcohol, I think there's so much people don't know about treatment and how you can do that medically. So we'd love to talk about that. Yes. As much as you can explain, that would be amazing.
Well, I think one of the things that really hit me was how common substance use disorders are. When my friend was taking care of patients with opiate use disorder and I was working as a family physician, I remember thinking, why would you do that? Why would you be working with that population? It was almost like this, ooh, yuck kind of feeling. Like, it was something I was really never exposed to. But then when I worked in my office as a family physician, one of my patients came in to see me and he had been throwing red flags that there was a problem. Like he was always coming in for opiates and always going to the ER, like, something's not right here. And finally he came and said, Dr. A, I have a problem with the opiates. Will you give me this medicine to treat it? And I said, I have no knowledge about that. I think you have to be certified. I don't know anything about it. So I called my friend and my friend said he'd see them, but unbeknownst to me, my friend didn't bill insurances. So my patient said, well, I can't afford to pay that. And so reluctantly I said, okay, I'm going to give you a prescription. I have no idea what I'm doing, but I want to do what I can to help you. So I gave him a script, contacted my friend. He got me connected with a drug rep who basically got me trained and certified on how to treat patients with opiate use disorder. And since then, I've taken care of college professors. I've taken care of attorneys. I've taken care of veterinarians. I've taken care of nurses. I've taken care of the homeless. I've taken care of work. I mean, I've seen the whole spectrum of people I've taken care of with opiate use disorder. And what really hit me with my one patient was he went to church with me. His kids went to Sunday school with me. This was if I use the phrase, normal person who had a normal life, married, working, and he had this problem that he didn't ask for. And there's so much fear, there's so much shame, there's so much, I don't know how to get help out there that a lot of people stay there. But he said something, and I'm so thankful he did because it really opened my eyes, it opened my heart to people who struggle with substance use disorders. Because again, it's not like he asked for it. It's not like, they say you want to put the brakes on, but you can't. The brakes just don't work. Yeah. And I understand that. I don't understand firsthand, but as a physician who's taking care of patients, hearing their stories, I understand. Yeah. And so how can I help them get control of their life again? And he's still one of my patients. Nice. We chuckle about it all the time. Like, I've been taking care of you since 2008. Yeah. And that's another important thing too, is opiate use disorder is chronic.
Right.
It's not you treat something for 3 months and ta-da, it's gone and that's it. I mean, this is a chronic disease. And that's not to say that people need medication indefinitely, but some people may need medication indefinitely, just like high blood pressure. We don't say we're going to treat you for 3 months and stop your medicine, because what will happen?
Yeah.
The blood pressure goes up again. So with any kind of substance use, it's a chronic condition that we have to understand is chronic. And medicine may help, counseling may help, meetings may help. All of them may be necessary. You might be able to come off the medicine. You might not. But guess what? If it keeps you out of trouble, you're doing your job, you're able to be the spouse you're supposed to be, you're a functional member of society, you're a successful person. Treatment has worked for you, and that's what it's supposed to do.
I think people have this mental image of someone struggling with that kind of substance abuse as like
a strung out druggie on the street.
Yeah, like riff-raff, like been in and out of jail. And all of those things can also be true, and they can still be a wonderful person, right? Like I think there's circumstances that lead people to that road. Could be an injury where they took pain medication.
Oh my goodness. I mean, with how many patients told me, I had one lady who I think she had either a C-section or hysterectomy, and her doctor was still giving her Percocet 6 years later. Like, no, why are you prescribing? So this person was addicted because their doctor kept prescribing something that they shouldn't have. And that tears my heart. Like, oh my goodness, just, how this person's suffering because something was prescribed and they were just never told no, that they weren't going to get it anymore.
And being that you were a pharmacist, have you seen this cycle of just like the prescribed medication? I'm sure, right? Because now you're doing this. So that's kind of a silly question, but like, what has the impact been of like seeing some of those prescriptions come through and just knowing that like, man, there are other options than just this prescription to help people?
So the last time I worked as a pharmacist was probably 2007 or 2008 before I opened my own practice. So it's been a while since I've seen that side, but I do remember what I saw then. And, and seeing some prescriptions over and over again. And, hopefully the patient's been evaluated and all those things that have happened. But I know that, where I worked at one point as a family physician, someone called the office and they wanted a refill of their Percocet, and their doctor was not in that day. So they sent a message to me like, so-and-so needs a prescription for Percocet. I'm thinking, so you just want me to just write a prescription for Percocet for someone who I don't know, who I've never evaluated, just because their own doctor's not there? How comfortable do I feel with that?
Right.
Because how comfortable do I feel with that? I guess it's really
well, and since then, and many lawsuits later, right? The opioid pharmaceutical companies have really got it, right? And they really cracked down on physicians about, you have to see people, you have to. We started tracking the ERs, right? Like that was about that time where things had to be tracked on a national level because people were pharmacy shopping, they were doctor shopping, and they were ER shopping to get their prescriptions for their habits to be met, right? And so some of that has been
clamped down,
sort of wrangled in. I would say there's probably still room around that, right? Like you can find ways around all those things if you really wanted to. I feel like people are very creative when it comes to that kind of thing, right? But
well, case in point, there was another person I saw who was not my normal patient, and they wanted a refill of their Percocet. And I said, well, let's check your urine. And, they said that they were taking it, but guess what wasn't in their urine? Percocet. So I wonder what's happening to this 3 months worth of medication that they were asking for all the time. So there's
so they're supporting somebody else's habit, or they're selling it.
Exactly.
Yeah.
Exactly.
Yeah. Wow. Yeah. You never know. Yeah. So what is the protocol? Do you mind actually medically speaking about what medicines you put them on, or does it depend on?
In my office?
Yeah. Like how you treat people.
Yeah. So when patients come in for an evaluation, we start off by doing urine drug test. What's in your urine? I'm expecting stuff to be in your urine. I mean, so don't stress about that, because I can't help you if you're not honest with me.
Right.
And I tell people one of the worst things you can do is lie, and especially don't let me find out. I'm trying to help you. So if they come in and they're positive for opiates, we typically give them a buprenorphine product. There's, Suboxone, Sublocade, Zubsolv, Brixadi. We start them off on one. We sometimes can put people on naltrexone, which is another phenomenal medicine. It treats both opiate use disorder and alcohol use disorder. The challenge is you have to have opiates out of your system for about 10 days to start it. And most people don't get to the point of having opiates out of their system for 10 days. So for me, someone who has been, either incarcerated or something like that, where they did not have access to opiates and they're negative, they would be the best candidate for the naltrexone, because otherwise they just have to get it out of their system. So they come in, we get them a prescription for buprenorphine typically. And then we have them follow up in a week, see how they're doing. Is the dose appropriate? Are you having these symptoms? If they're fine, we typically see them every 2 weeks until they've been in treatment for 3 months. And that's kind of Ohio law. After they've been in treatment for 3 months, then we can see them once a month. If they're not doing well, then we make adjustments. And then along with that, we also recommend meetings, 12-step meetings or personal counseling, whichever, because I explained that with addiction, there's 2 parts. There's the physical part and there's the psychological part. The physical part is the cravings, the withdrawal symptoms, et cetera. So the buprenorphine typically helps with that. But then you have the psychological part. Why do you use? What are your triggers? How can you be in that environment and not go to using? And so that's where, again, the meetings, the counseling are very, very important. And I tell patients, it's like a dress rehearsal. Life's going to throw curveballs at you. And so I want you to succeed getting to those scenarios really before we even try to wean. Because if you haven't hit those yet and we lower your dose, you're going to be more likely to relapse just because you haven't had that success under your belt.
Right.
And so afterwards, typically we see patients once a month, and it kind of depends on the patient. I mean, some patients were able to wean off of medication. At the same time, if the medicine does what it's supposed to do, you have a chronic medical condition. I'm not necessarily trying to rush you to get off of it. We don't want to give you more than what you need. And so with time, we try to reduce the dose. We try to go down a little bit and see if someone tolerates it.
Yeah.
And if so, awesome. And if not, okay, we'll keep you at your dose and we'll revisit that in the future.
What is your thoughts on methadone?
So with methadone, it's a full opiate agonist rather than buprenorphine's a partial opiate agonist. So you can get high off of a full opiate agonist. And to get a prescription for methadone for opiate use disorder, you have to go to it's like an outpatient center. Very specific facilities are able to prescribe methadone for opiate use disorder.
Right.
In general, it can be prescribed for pain, but for substance use, you have to go to a specific kind of facility.
Just curious.
And so they're different.
Right. They're different. And, we have had patients who come off of methadone and switch to buprenorphine. I've had patients say that the methadone dose was too high. They're having side effects from it. And then, of course, having to go to the facility daily can be quite cumbersome depending on who you are.
Right.
So we don't use that in our office because we're not one of those facilities that have done those extra criteria, but we typically use buprenorphine or, like I said, naltrexone.
Yeah. What are the side effects of those medications that you see, like the full-on methadone versus these? Are the ones that you guys use have less side effects than methadone? I know methadone can have quite serious side effects long-term.
Well, and a lot of that also gets into dosing.
Yeah.
Methadone, you typically have very, very high doses. All opiates can cause constipation as a side effect. So both buprenorphine, which is a partial opiate agonist, and methadone, which is a full opiate agonist, they can both cause constipation. Also with buprenorphine, headaches, problems sleeping. But I tell people a lot of times they're going to sleep better after they've been in treatment because they're no longer doing the crazy stuff they used to do. So they're feeling better and they can sleep better. And those are probably the biggest that we see. It can cause liver problems, especially in people who have liver disease. Yeah. So we typically check a liver baseline blood test, Hep B, Hep C, and then we also check HIV. But that's the main thing that I see, at least with the buprenorphine.
Lymphedema, I know methadone, some people get some real significant lymphedema. Mm-hmm. Do you see that with the others that you guys use?
Not with buprenorphine. Yeah. I mean, again, I don't prescribe methadone, so I can't speak firsthand of a lot of that just because I don't see that. But our patients, they do well. Yeah. They do well. We do drug testing. We do random drug testing. I think that's a very important part of what we do as well. I have a patient who transferred me from another office who they didn't do random drug testing. And they did a lot of telemedicine. And this is one of my whole concerns about telemedicine. And she told me that she would stop with her other stuff prior to going into her visit because she knew she was going to test. And then after her visit, she went back to using her other stuff. And she'd been doing that for who knows how long because there's that lack of accountability in the sense of a scheduled drug test you can study for, a random drug test you can't. And I think that's one of the really strong points of what we do because it's all about accountability. You know, if you know you can be selected, it's going to help you not do what you shouldn't be doing anyway, which is ultimately helping you to be sober, which I would think that that's your goal.
That's the goal.
Do you feel like the people who get addicted because they had an injury, right? Like taking the medicine and they had an injury and it was a prolonged injury that they just had to take narcotics for because they were in a lot of pain, right? Do you find those people have more success rate getting off? Do you like the mental component, right? When you talk about treating them at a twofold, or do you feel like there's a psychological addiction that happens even with those people long term? Does that make sense? Does that question make sense? Like, I understand having triggers and you know, but not everybody's walking around with an injury and then an opioid addiction, right? So do you feel like those go hand in hand, that they have some trauma and they're more likely And therefore you treat both ends, or is it possible that somebody just got addicted from on accident from an injury and they go on meds and then have some sort of psychological dependence that happens?
That could vary from person to person.
Okay.
I mean, I know I have some patients who feel psychologically like they need to take the medication. But I also don't know if that's fear of withdrawal if they don't, because that's very legitimate.
Yeah.
You know, if you don't take it and you withdraw, I can see that being concerning.
Withdrawing is pain. It's extremely painful and terrible to go through. Like, it's awful.
Yeah, it's uncomfortable. I mean, the nausea, the vomiting, the diarrhea, they can't sleep, the goosebumps, et cetera. And then some people can get physical pain with that. Now, as far as someone who had chronic pain, you know, one of the nice things about buprenorphine is it is a partial opiate agonist. So it can be used to treat pain as well. So you can have a fringe benefit of pain reduction by staying on buprenorphine. So if you did have that injury, this may be a better way to treat that discomfort and at the same time prevent the cravings and withdrawal symptoms and going on to use something else, or, you know, potentially something that's cut with something else. Yeah. So, you know, there's that. You know, we do sometimes talk about the psychological of, okay, is it a habit? And this is one reason why I want patients to take their medicine once a day, not multiple times a day. Right. Buprenorphine is designed to be taken once a day. It has a half-life of about 37 hours. So 37 hours after you take it, half of it's still in your body. I tell patients, you know, if I gave you penicillin to take 4 times a day for strep throat, what's the likelihood you do that?
Right. Maybe 0.
Twice, maybe.
Exactly. I mean, I took a box or Augmentin once for a sinus infection. I had a hard time remembering the second dose. You know, once a day is best. That's why so many antibiotics are once a day. But with addiction, you want to take something several times a day. You know, is it time for my next dose? So they'll want to take it 4 and 6 and 8 times. That's part of the behavior of addiction. Yeah. So I try to talk to patients initially about we want to break that habit. It's designed to be taken once a day. You get up, you take it, you're done for the rest of the day. Let's try to break that habit of multiple daily dosing, because again, that's where some of the psychological part is. And if you really feel the need to take something later, maybe put a mint in your mouth. Yeah. Or do something else. Right. Or especially later in the day where a lot of people have symptoms, you're bored. You're no longer at work. Right. You know, the mind starts going places because you're not actively doing work. That's a great time to go to meetings, to connect with other people, as opposed to staying by yourself and then potentially feel like you need to take something.
Yeah.
That's so interesting. Yeah. Well, just shift a little bit. I would love to talk about weight loss and what kind of got you into that. I know that you mentioned someone reached out to you about it, so that's how you got certified. But talk to us about how you treat that and what you've learned along the way.
Yeah. So the thing that's so important is 75% of all American adults have obesity or overweight. That's huge, 3/4 of everyone. And the reason why it matters is because obesity-related complications are the number one cause of premature preventable death. So when you think about type 2 diabetes, high blood pressure, high cholesterol, heart disease, these are so often related to an excessive amount of weight. And so my passion is reducing those complications, and losing just 5 to 10% of your weight can greatly reduce the risk of those complications. So my initial goal when I see someone coming in is to help them lose 10% of their weight. And we see it all the time, and we have a lot of fun with it. And so when a patient comes in, we start off by doing a body composition analysis, which is a special scale. It tells us how much fat, muscle, and water they have. It tells us their metabolism, and then it predicts how much weight they can lose in 6 to 8 weeks, depending on how aggressive they want to be. And then we customize a program for them. So, you know, do they want meal replacements? Do they not? Do they want to use regular food? Do they need medicine? It's, you know, we kind of pick and choose and piecemeal things to help meet their needs, and depending on what they decide could determine how quickly they can lose weight. And then depending on what they do, we follow up every week to every 4 weeks to do another body composition analysis. That's a very important part of what we do, because we want to make sure that people are losing weight safely. And especially with a lot of people using GLP-1s, we know that people are losing a lot of muscle, but not in our office. They're maintaining their muscle because of some of the other things we do. And that's, you know, just attest to the success of our programs.
So you kind of use that medication along with like a program.
Oh, yeah.
To help make sure.
Yeah, the program is the foundation.
Right.
You know, it's a map. You have to have a map on knowing where you're going. You know, case in point, when I was working as a family physician, I had someone who said, oh, by the way, can I have a prescription for Adipex on my way out the door? Well, my friend takes it and she eats donuts all day. Like, you're not going to lose weight. That's and it frustrated me to think, well, who's prescribing it? You know, like, do you know that this is what your patient's doing? You're setting them up for failure because they don't have the tools and the structure they need to succeed. Right. Whereas for us, we prescribe a program. This is how many calories. Here's how we want you to do that. You may need medicine. You may not. I've had patients lose over 100 pounds without medication.
Yeah.
They were convinced they're going to need it. They didn't. And that's a success of, not needing medication. But I've had so many patients maintain their muscle, if not gain muscle, while on a program and using a GLP-1. But we also have patients who aren't on GLP-1s. I mean, those are not the only medications out there. And we see a lot of success there. So, but with doing the body comp follow-up, I had a guy who lost 7 pounds in 2 weeks. And you would think that would be great, except only 1 pound was fat. The rest was muscle and water. There's no way we would have known that if we didn't do the body comp. If we just did a weight only, we would not know what's going on in the inside. So we would not have been able to know we need to make changes to help him lose the right stuff.
Right.
So that's a very important part of what we do.
And it's hard with like diet culture and people who are on the GLP-1s, right? Is people want the quick, okay, the scale's changing.
Right.
Without truly realizing what's happening internally.
Right.
And I just think that is a huge topic of discussion of just people not understanding that scale is a small little tiny, the scale that we have at home, not the scale you have. The scale I have is one small piece of the puzzle.
Right.
Not telling a full story.
Right. Again, because for me to be able to tell someone how much fat they've lost, what their muscle's doing, that is so much more important. Or we've had times for people where the scale breaks even and it doesn't show any change, but they gained muscle and lost fat.
Right.
Again, we couldn't tell them that without the body comp. So that's, we try to explain to people why it's so important. We want to make sure that they're losing weight and that they're losing weight safely.
And I think that's more important for women. Do you see that more in women where you're gaining muscle and losing fat and not seeing a big change on the scale? Is it more women or is it both?
I mean, in the times I've seen it, probably been more women.
Yeah.
And then, of course, with females, we have our cycle that can play a role in things. And so, sometimes we don't see as much change because someone's about to start and then we see it in the next time around. And so we, of course, encourage them like, hey, hang in there. You're doing all the right stuff. You'll probably see it on your next visit.
Well, and hormones are such a huge swing, right?
Yeah.
It's really all about hormones. And I feel like it's so frustrating, I think, across the board for women. How many times have you gone on a diet or started to work out with your husband only for you to see nothing on the scale? And he's like, I'm down 12 pounds.
Right. I stopped drinking Pepsi.
I stopped drinking Pepsi and I no longer have candy bars. And now I'm down to 18 pounds. And you're like,
yeah.
Like, cool. It's so frustrating as a woman, right? To do that. And I feel like women doing things with their boyfriends and it can be really frustrating. And I feel like that's a great tool to feel like if somebody told me in those moments, like, no, you're gaining muscle.
Yeah.
What you're doing is working.
Yeah.
Just keep at it.
Yeah. Yeah.
It would
Screw
feel
what
different.
he's got going on. That's, like it's not about him. It's about you. That could be really encouraging information.
Yeah.
When it's really easy, when you've been working so hard, because it's not easy to change your eating habits and your workout habits. And you're like, 21 days. I can do it for 21 days, right? If I make it to 21 days, it's a habit. It's a new habit. That's what they tell me. I can do it. And at the end of 21 days to go,
what do you have to show for it?
What? Yeah. The scale is literally the same, or you're down 2 pounds versus their 20, right? And so I think that's really great to find some pieces that you can show them that they're making progress.
Right.
It's not always just about the scale.
Right. Well, and something you said that was interesting too is understanding that guys typically have a higher metabolism than ladies.
Right.
And since they have a higher metabolism, it's typically easier for them to lose weight. If they reduce their calories versus if we reduce our calories, guys are they're going to lose it quicker. Now, at the same time, I like to point out, though, that the exercise per se doesn't cause weight reduction. It's the reduction in calories.
Right.
Reducing your calories is going to cause weight loss. Your exercise is going to keep it off to help maintain your muscle, maintain your metabolism. So those things are very important to continue doing. But sometimes I have to tell people just because you're going to the gym doesn't mean you're going to be losing weight.
They say abs are made in the kitchen, not in the gym, right?
Right.
Because
Right.
it's so true. You can't out exercise a bad diet. And I think now, just with different things, people just assume, like you said earlier, well, my friend's eating donuts, it's fine. And it's like, cool. But really, truly, what you're doing internally is not helpful.
Right.
Well, and there's things like skinny fat and, there are people who are thin, but really have a large fat content, right? Have visceral fat, which is abdominal fat, which is the really dangerous stuff. Those people aren't necessarily healthy
Right.
Just because you're thin doesn't mean you're healthy. Right. And so it's getting to your body to be it is an amazing machine. And recently you just had a test done that you were like, oh my God, it's the most amazing thing to watch our body work in real life. Right. Yeah. And we just don't understand that our bodies are amazing.
Oh, they're very amazing. Very, very fabulous.
It is so cool what our bodies do automatically every day for us, and the way your body can adjust to account for toxins and account for your environment and account to a point, right? And at some point you might get to a breaking point, and that's where disease comes, right? That's where it comes from. And how do you get back to homeostasis for your body? And people just don't understand that. It's not a quick fix always. It's not always a quick medication that gets you there. Sometimes it's a nutritional deficit. It's you have too many heavy metals in your body. You've been exposed to too many toxins. Your liver really needs a flush out. Like you're at max capacity with your liver. Like it's a filter. Your filter's clogged. Right. People just don't understand. I don't think really connect all of those dots to understand that your body is such a well-oiled machine that
I think the key though is wellness. Is understanding the importance of wellness, because we tend to not do anything until there's a problem. Right. And it goes back to what I said before, an ounce of prevention's worth a pound of cure. Yeah. So you have to have that mindset of what can I do to prevent a problem later, as opposed to waiting until the problem actually comes up. Right. I was going to say also with the weight loss consult, we also do blood work. So, what's going on the inside. And we check a fasting insulin, we screen for diabetes, we check your cholesterol. And then because sometimes they need help as well. And then we also check later to see if things have gotten better. But that can give a lot of insight of, is there inflammation? Is there something else? Do you have food sensitivities? Right. Sometimes we do testing for food sensitivities. And then again, talking about the types of food you eat, how you prepare the food. That's a whole other thing. How do we prepare food?
I eat fish 4 times a day, but I fry it every time in deep seed oil.
What is a common thing? Like, I'm sure there's many things. A common thing that you see that people do wrong that maybe most people would feel like is harmless. Like, is there something like dietarily that you feel like?
I like to talk about empty calories. It's funny you mentioned about the pop, but empty calories in beverages. Most of us don't get enough water. We should have about 8 glasses of water a day. And I have had patients who said they've lost weight by getting rid of the pop. There's no health benefit in pop. Yeah. And so you think about all the other stuff you're putting in your body, drink more water.
Not to mention the amount of sugar you're consuming.
Yes. And then when you start talking about diet pop, okay, now you have these ingredients that is your body designed to process. Right. Aspartame, all this other stuff that can cause its own set of problems. I mean, some things have shown how those affect neurotransmitters that play a role in depression and things. So you're putting in these artificial chemicals that can have other effects in your body.
Totally.
So I would say the empty calories, the other thing I talk to patients about is alcohol. Recommend no more than 1 beverage with alcohol a day, because alcohol has calories and alcohol tends to make people want to eat more. And I've had several patients who say, every time I go out and have a glass of wine, I tend to want to eat more. And I've had probably 3 or 4 ladies who've noticed that when they get rid of the alcohol, the weight comes off. And they're just sensitive to it. I mean, not that there's a problem with it per se. They just happen to be sensitive to it.
I mean, literally, I've lost 90 pounds in 2 years. And I'm doing the exact same thing, except I stopped drinking. Yeah. And that, I think to your point, people can be very, very sensitive and not realize maybe my friend over here, not Christy, maybe my, friend A can consume alcohol and that doesn't impact, but it might impact me completely different. Yeah. I just don't think people think about that.
Yeah. Well, the amount of inflammation we carry around because of all these things, and especially alcohol. Alcohol is a poison. Yeah. And the AMA has come out and basically said that recently, right? So it's not like this is news. Yeah. It really is poison, and all that causes inflammation. And how much you take in is how much inflammation is in your body is going to directly impact your weight, your mood, all these things.
We know these things, right? And all this stuff comes out, but we're like, I would rather starve myself than stop drinking alcohol. I would rather bring a Mio squeeze bottle and get a vodka and water and put a little sweetener in there than stop drinking. Just stop. Like, but it's so hard. It's so into our society.
That's where it gets into habits. And so again, we talk about the habits that we have to really take a look at our habits. What can we change? And that's where the counseling comes in. Is, we do talk about habits. What can you change? What can you do differently? Because if you do what you've always done, you're going to get what you've always gotten. Yep. Yeah. So I want to help you. I want to help patients do something.
Yeah.
So we did see on your website, you also have some med spa services. Can you talk a little bit about those?
Yeah. So A lot of them came about from helping people lose weight. And as people lose weight, the skin starts to get saggy and et cetera. So we started off by offering body sculpting, where we can tighten skin, trim fat, tone muscles, help people lose inches. And so it's there to complement their weight loss journey, to help them feel better in their own skin. Then we also have anti-aging facial treatments that help define the cheeks, define the chin for a more youthful appearance. And then we all like smooth skin. So we have laser hair removal as well. So we can treat, the arms, the face, Brazilian bikini, legs, etc. And it's all to help people feel better. And, my motto as a physician is enhancing your health and wellness to improve your quality of life, to help you look and feel your best on the inside and out. Nice. And that's really everything that we do in the office is geared towards how can we do that.
Yeah. That's awesome.
And then it makes it a lot of fun because we succeed and, the patients, they're glowing because of their success. And then it's just, it's fun.
Yeah. I'm assuming, and most people in your position, you are not an insurance-based company. Because we'll get asked that question.
So we are a network with insurances.
Okay.
When I started, and my friend who I trained under, he did not bill insurance, so he taught me how to run a business without insurance. And then in 2009, when Obamacare recognized obesity as a medical condition, all of a sudden insurances started to pay for treatment of obesity.
Oh, nice.
So we went and networked with insurance companies because we would actually get paid better that way versus what the cash pay price was, because we were just charging just a low amount. So we started getting paid better by billing insurance companies. And so we're in network with most major insurance companies here in Central Ohio.
Awesome.
That's
and that
amazing.
For the weight loss part and also for the opioid treatment part?
Yep. For opiate use disorder, medical weight loss, alcohol use disorder, they do not cover med spa services. That's considered purely cosmetic, but we're very, very affordable and competitively priced for that. And then the other service we offer is hormone balancing. And what that has to do is treating menopause and perimenopause in ladies and low T in guys, and then also thyroid disorders. And one thing that I tell patients is that for women, the average age of menopause is 51. But about 10 to 15 years before menopause, women start to lose another hormone called testosterone. But most doctors don't think about testosterone in women. They don't check it and they don't know what to do about it. And I was one of those doctors until I started studying balancing hormones. But when I learned testosterone is a brain hormone, it helps with anxiety, depression, sleep, memory, attention, concentration, helps protect the heart from heart disease, helps protect the breast from breast cancer, helps protect the bones from osteoporosis, helps protect libido. It does a lot of good stuff. And when I think about how many ladies are suffering from these symptoms, especially menopausal, one of my patients said when they hit menopause, they expected to go on Premarin for their hot flashes and Lexapro for their mood, because that's what all their friends did. That's like the menopause concoction, but nobody ever thought about testosterone.
Right.
And, all these other symptoms that ladies late 30s, early 40s are suffering from, and they get, see their physician who, if they're anything like me, I wasn't trained on hormone balancing in med school. So here, take some Lexapro, take some Prozac, et cetera. Whereas maybe it's because your testosterone needs some help. Maybe that's why you can't sleep. Maybe that's why you don't have any libido. Maybe we can help you feel better if we optimize your hormones again. So that's another.
I love the word optimization, and I would love to talk about that a little bit. Okay, because I think that the Western medical world, the way they're trained is you're within normal range. And people, and I have a close friend that has Hashimoto's, right? Like your thyroid can be within normal limits and you can feel like absolute dog shit, right? So it is not about your hormone levels being in some arbitrary range. It is based on you and how you feel.
Right. And so a couple of important things. There's a difference between normal and optimal. Yes. And then when they look at, quote, normal, well, whose blood did they check to find the normal range?
Thank you.
People who aren't healthy.
Not mine.
Those ranges on what's, quote, normal. Okay, but healthy people aren't getting their blood checked. So it's really skewed towards people who are not healthy to begin with.
Right.
So it's a combination of symptoms and labs. I don't go by labs exclusively. I put a lot of emphasis on symptoms, but a lot of symptoms can overlap. Yeah. People can talk about insomnia. Okay, well, maybe it's because your testosterone needs help. Maybe your estrogen needs help. Maybe it's because you're sleeping on a tack or something. I mean, to play a role in sleep. Yeah. So, we kind of take them all and look at the big picture.
And I have a perfect example for myself. And I'm not trying to throw my nurse practitioner under the bus. I'm 53. Started in the last 2 years having serious menopausal symptoms. I'm not completely there yet, but I'm almost there. And I was having debilitating joint pain and weight gain. Those were my big things. I was still sleeping decently, but like my joints were all of a sudden like overnight, as in I'm some like 90-year-old arthritic person. And I'm like, what is this? And I'm a very active person, always worked out my whole life. Like, this came on like overnight.
Yeah.
So she tests my hormones. Great. Obviously my estrogen's low. My testosterone is on the low end of normal.
Mm-hmm.
Okay. And so I'm like, okay, I want to go on hormone replacement therapy. I need to do something. I feel like an old lady. Great. She gives me just the estradiol patch. And I said, what about my testosterone? She's like, I don't want to prescribe that for you yet. I have low libido. I have brain fog. I have like all of the things, right? And I explained this to her, but because my testosterone was in its normal range,
or for a menopausal lady,
you don't want to give me any testosterone treatment, which now you're saying is probably what's causing my joint pain, because the estrogen hasn't helped my joint pain.
Yeah.
And it also hasn't helped my libido.
Yep.
And it also hasn't helped my brain
symptoms.
Connecting my brain to my mouth. Oh,
yeah.
So frustrating. Like, I'll be talking to her and I'll be like, I can see it and I can describe it. And it's like,
low T.
I can't get the words out of my mouth. And it's so frustrating as an educated woman to be like, I sound like I am a ding dong because I can't get anything out of my mouth. So it's frustrating. It's frustrating. So frustrating for women who are like, it's normal. You're in the normal range.
Right. Yeah.
And you can't get anybody to help you unless you go to these clinics that aren't taking your insurance. And by the way, y'all, my out of pocket for my lab work was $400. Right? Like, I have insurance.
Yeah.
You know, this isn't a cheap venture. It's not a cheap thing to go down, even if you have insurance, right?
And so think how many women are just suffering because they can't even afford.
They can't afford to get it done. And I'm like, nobody told me what it was going to cost.
We send people to LabCorp. Let LabCorp bill your insurance. I mean, when you come in for the evaluation, we send you to the lab. LabCorp does your blood work. They bill your insurance. So basically, you're paying your copay.
Yeah.
Your deductible for a consult.
Right.
And then we talk about treatment options. But what you said was interesting because your labs are normal for, quote, a menopausal woman. Well, do you want to be functioning like a menopausal woman? Exactly. But that's the whole point. And so when we look at labs, well, normal for people in that age group, well, so are these symptoms. But guess what? Now we're suffering. You know, I want people to age in a healthy way.
And there's some disconnect, I think, too, from putting people on, why would you not give me testosterone? Because I'm within the normal range, but I'm still suffering. So why not just start me on a low dose to see if it helps me? Right. Like and there was a whole, like the Women's Health Initiative. I don't know if you want to talk about that. That scared people from going. That
was more on estrogen.
Yeah.
So I'll go backtrack again and say most of what I do, I did not learn in medical school and I did not learn in residency.
Yeah.
I learned on my own when I started my own business. So if I didn't learn it in medical school, there's a high likelihood that there's a lot of other doctors out there who didn't learn it in medical school. And that's not to say that they didn't learn that. This just isn't something that was taught. And so now if you're talking about testosterone, which is a controlled substance. So now you have, potentially a nurse practitioner who might not feel comfortable prescribing it, or they may not be knowledgeable, just like I wasn't knowledgeable until I started studying on my own. But back to is what you said, Nurses Health Study and the Women's Health Initiative. When I was in medical school, the standard of care was once a woman hit menopause, she was given estrogen for the rest of her life. And we had 80-year-old ladies in the hospital we were given estrogen to. That was what we did until those studies. And they came out and they said that estrogen's bad for people. And so it scared people from using estrogen. But the problem with these studies is they were based on oral synthetic estrogen. So when you take oral estrogen, it goes to the liver and it activates the clotting factors. And that's why ladies are getting blood clots. And the synthetic estrogen causes the blood vessels, the heart to spasm. That's where they're having heart attacks. And then synthetic progestin, not natural progesterone, but synthetic progestin increases the risk of breast cancer. But they downplayed those nuances and kind of just said hormones are bad. So now most doctors are scared to use hormones. They might give you hormones for maybe about 5 years, just a teeny bit to take the edge off of hot flashes and leave you to suffer, which is the exact opposite of what we had done when I was in medical school. And so that's with estrogen. Now, the Women's Health Study did not look at testosterone. It was more synthetic estrogen, synthetic progestin. And those were the conclusions they came to. But that caused a lot of people to be scared. And as a result, a lot of ladies are suffering because they have all these symptoms. And, I use common sense 101. If estrogen's bad for you, why do you have to begin with?
Yeah.
You know what I mean? No, it's important to be balanced with progesterone. And there's a lot of people who have excess estrogen relative to progesterone. But if it's bad, why do you have it to begin with? And if having lots of estrogen is bad and causes breast cancer, well, I would think a lot of the people with high estrogen levels would have lots of breast cancer. But I don't know any 20-year-old with breast cancer.
Right.
So is it really the estrogen or is it something else? So I kind of call that common sense 101 of why do we have it to begin with? And if high levels were bad, then why don't we see this kind of problem in younger women?
And back in the day, right, women would only live until they were about 56. So you would go through menopause and then your life expectancy, you only really were like 4 or 5 years. And as our longevity has increased, right, and now we're living into our 80s and 90s, we're spending half of our life in menopause, right? And so they're directly linking it now to osteoporosis and all of the lack of hormones for that long is leading to all of these elderly and being fragile and breaking hips and breaking bones, when really that can be prevented with hormones. And by the way, if this was men suffering with low T for this long, we would have already had it fixed. You know what I mean?
Right.
It wouldn't have been a thing. They wouldn't have tolerated that for that long a period of time. And so we've just come to accept that, well, women, once they hit menopause, they really don't want to have sex. And, your libido will come back eventually. It does shift back. But for what was really like 15 to 20 years, you don't.
No one wants to be out here like about.
And it's like your most virile time, right? It's like you're done raising your kids, and this is like your time, and you feel terrible.
Yes.
And I want to be virile. I have 4 grandbabies. I want to hang out with them and play. And I ran around and chased. And now I will say that since I went on estrogen, my energy level has increased significantly. But I'm still not. Like my joints still ache, and I'm still and I'm so glad to hear you say that it's testosterone, because I just think women need a great source of somebody to come and go like, who has educated themselves, because and it's not, I love my nurse practitioner. It's not her fault. She's not getting this training.
Right.
But who do you go to unless you go to these boutique places that are managing, you can get them online, but it's like your initial consultation is $500 and every hour after that is $250.
Right.
And you're going to pay out of pocket for your labs. And, and you're like, okay, well now I'm $3,000 in.
Right.
And most people don't have that kind of extra income to be able to tackle it on top of their insurance payment, right? Like you're paying a lot of money for insurance that we want to be able to utilize.
Right.
And so it's nice to see that there's some options around town that allow for insurance billing.
Yeah.
Which is really great.
And it's fun. I mean, when people come in and when their hormones get optimized, they feel so much better. Their quality of life goes up. And again, that's where it gets fun, because we can see them coming in smiling. I have one lady who comes in and she goes, yep, my husband said it's time for me to get my it makes a difference. Or I had another lady who was referred by one of her subordinates. And so she came in to see me and we treated her. And then her subordinate came back and said, thank you so much for treating her. She's like, but it's true. I mean, the effect it has on us, but we suffer. We don't know that we don't have to suffer. We don't know where to go to stop the suffering.
Right.
And as I said, with our office, we bill insurance. So you pay your copay or you pay your deductible, and
That's awesome.
And you pay per visit. So it's not like you're signing a year contract of doing anything. You just pay when you come in, just like when you see your primary care physician.
It's amazing.
Yeah.
And where is your office? Where can people look to book an appointment? Are you taking new clients? Talk to us a little bit about that process.
So we're in the northwest side of Columbus, kind of the Bethel Road, Salma Road area.
Yeah.
Our telephone number is 614-442-2600. You can visit us online at www.prohealthservices.org. There's a button there where you can actually go ahead and book your appointment yourself if you want, or you can give us a call and we'd be happy to schedule you. We're taking new patients. I'm simply trying to help as many people as I can, because, when you see people suffering and you know that you can probably do something to help them, that's why I'm a physician to begin with, because I want to help people feel better. And it's fun.
Yeah. Talk about the pellet therapy for a real quick minute.
Yeah. So that's actually how I got started. I had a company come to me and they were basically doing pellet therapy, and I got trained to do pellet therapy. And so pellets have been out since 1939. So they've been around for a very long time, and they were given to ladies who had hysterectomies. And they found that these ladies needed some testosterone. They needed estrogen. So they take pure testosterone powder and compress it really, really hard into a pellet about the size of a grain of rice. And they do the same thing with estradiol powder, compress it really, really hard. And we do a procedure in the office where we insert the pellets in your hip. And I use a little numbing medicine, make an incision, insert a device called a trocar that makes a tunnel under the skin. Pellets go in, trocar goes out, put some steri strips on, and we're all done. And then it typically lasts about 3 to 4 months. Now, I do say that this is not something that insurances cover. Pellet therapy is considered experimental in ladies, and we don't bill insurance for the pellet procedure anyway, because for guys, I use higher doses than the Testopel dose. And I tell people, I'm not going to argue with your insurance on why I'm treating you. I'm treating you based on what I feel is best. And I'm not going to go into a paper battle with them trying to practice medicine without a license.
Right.
So, but I would also say treatment's affordable though, as well. I mean, I don't want treatment to be cost prohibitive to anyone because I want people to be able to get the care they need.
Yeah.
The pellet therapy is great. I mean, you get the pellets in, you don't have to think about them anymore. They last a while.
Do you go on the same spot every time? So is it the same like little scar
we go back
place?
And forth. We go back and forth.
So there's one little spot on each side that you go into, but it's the same spot.
Pretty much. I mean, sometimes you go near that same spot just because you can get scar tissue building up.
Okay.
And so sometimes it's good to go a little bit around it so it's not tackling that same spot. But we offer pellet therapy, which the majority of our patients do pellet therapy. Okay. We also offer topicals. So we have people who are on compounded creams. We also have some patients who we can use a patch. The problem with the patch is it's only estrogen. So what do you do with your testosterone? What do you do with your progesterone? So now you're doing 3 different modalities as opposed to pellets. We typically do estrogen, testosterone together, and then oral progesterone. Or if you're on a topical cream, we do testosterone as one cream, and then estradiol and progesterone as another cream. And then eventually try to blend them into one once we have your doses at their sweet spot.
Wow. Yeah. I would love a compounded patch. That would be fantastic because I hate taking my progesterone at night. Isn't that a weird thing? Like I'm like, I don't remember it.
Put it in your nightstand. Take it before you go to bed. Helps you sleep.
Still, I have it there, but I don't know. It's still, I hate taking pills in general. Like I'm really terrible at it. And I asked for a compounded cream and she just sent me the estradiol patch. So, that was like, I was like, I want something. So she just was like, okay. Yeah. And then I'm like, well, am I asking for something that's not real? Like I started questioning my own research.
But now you're talking compounds.
Yeah.
How many healthcare providers know about compounds?
Right.
And as a previous pharmacist, I used to custom make compounds.
Right.
And, I learned all about those. But how many other physicians and nurse practitioners know about the ability to have things compounded? Know where they can send someone to for compounding, know how to prescribe something that's compounded, because compounded is specially made for you. Right. A lot of people just are quick to write something that's over the shelf there at the pharmacy that's FDA labeled. They just, whatever, as opposed to customizing something for you.
I have to say, thank God there's people out there like you who literally are like, I'm going to do this myself. I'm going to learn these things myself and figure out what's best for people. Because I'm in awe listening to you and obviously incredibly intelligent, but just the wanting to help people and taking all that you've learned throughout different career pathings and then taking education in your own hands to saying what can I do to really serve people? It's just so beautiful. So thank you for doing all of that. That's incredible.
Thank you. I mean, I really have fun with what I do. I love my job. I go in there, I'm smiling, my staff is awesome. Patients come in, they enjoy the experience. It's, I want it to be a pleasant experience coming in. And it's so rewarding. There's so many intangible benefits of just, seeing the smile, seeing people feeling better. Again, the lady comes in, my husband says it's time for me to go. Because the pellets wore off. I said, well, that testifies that they work for you.
Yeah. I have a friend that started pellet therapy probably in her early 50s. And she was like, I will never be off of them. I will never stop taking them. It had such a major drastic change in my well-being, the way I felt. She's like, I'll never not be on them. Yeah.
But they're the hormones you're supposed to have.
Right.
I mean, that's the thing. It's giving you back the hormones that you're supposed to have. And you felt so much better previously when you had the hormones. They just go down with menopause and the aging process. But do you want to feel that way? Or do you want to feel optimal?
Right. Do you feel like when you start people on therapy, does their periods come back? I think that's another question that people have as far as menopausal women is when you start, by the way, fully menopause means that you have to be without a period for a full 12 months. And I have friends that are I got to 11 months and then I had a period. I've had a hysterectomy, so I can't tell except for my hormones. And she's like, you're not quite there yet, but you're almost there. And I can tell, I can still tell hormonally that I'm like, I think that would have been a period.
Oh, yeah.
The hormonal shift I feel. I'm very sensitive to my own emotional roller coaster, if you will. So do you feel like when you start people back that some people will start having periods again and it kind of prolongs the menopausal process?
So we don't want people to bleed once they're menopausal. But the biggest side effect of estrogen is vaginal bleeding. And that's why it's so critical to take progesterone, because the progesterone helps protect the uterine lining to prevent the vaginal bleeding.
Right.
Because if there is bleeding, then we have to worry about endometrial hyperplasia, which can lead to endometrial cancer, endometrial carcinoma. So it's very important that if a female still has her uterus and they're given estrogen and they're menopausal, that they take the progesterone to balance that out.
Yeah.
If they're premenopausal, we tend to use more testosterone, just because they might have a healthy estrogen level to begin with, which is why they're still cycling. But we do have some where we've given some low dose estrogen too, and then, balancing out the progesterone to try to keep their cycles pretty regular until they get to that stage where they're not having them anymore.
Yeah. Yeah. So you don't want to see that. That makes sense.
Yeah. No, we don't want to see people bleeding afterwards, because then we have to worry about badness.
Yeah. And since I had a hysterectomy, she's like, I don't have to give you progesterone unless you need it. And I think that's an interesting thing, is that it's still based on the science that they're being presented, not based on my symptoms, right? Like if I came to her and I'm like, I'm completely an insomniac. I can't sleep. I can't, so would you then go ahead and put somebody, that's what I want people's physicians to do, is like base it on what their symptoms are and not based on, well, but you've had a hysterectomy, so I don't have to give you progesterone, or
So when I started, I was taught that if you have a hysterectomy, you don't need progesterone. But a few years ago, I was doing a continuing education and really shifted towards offering progesterone to everyone, because you can have symptoms of too much estrogen. So offering the progesterone to balance it, because you have progesterone receptors in other parts of your body too, not just in the uterine lining. So it can still offer benefit. It can help as a diuretic. It can help with sleep, among other things. So I still offer progesterone.
And it's called estrogen dominance when that happens.
So sometimes people have too much estrogen relative to progesterone. And I typically see that in younger ladies. And that's estrogen dominance. And that can cause, really heavy periods, heavy flow, other symptoms like that could just be they have too much estrogen relative to progesterone. And so some younger ladies, we give progesterone too to help balance that out.
My body was every bit of estrogen I was given. Thank you. There's not too much you can give me at this point, I don't think. Although I'm on the most low dose that you could possibly get because I'm a sensitive soul. But yeah, thank you.
Yeah.
Really. I would love to come and see you.
Yeah.
To balance out my hormones. That would be fantastic.
And we will make sure we put in the show notes everywhere where people can find you, your website, your phone number, all of that, to make it easy for people to stop in and see what you offer.
Yeah.
So, well, before we end today's episode, we always like to ask, are there any women in your life that you would like to give a shout out to that you feel like have helped along your journey? Maybe maybe people you don't know, but inspired you. So,
well, my mom reminds me that when I was a little girl, I once asked if I could be a doctor when I grow up. And she said, sweetie, you can be whatever you want to be. Oh. And so that kind of let me know that was an option for me. And I have a classmate actually we met in middle school. It was a brand new school. And I'll shout her out by name, Dr. Teresa Lee Namath, who lives in Chicago, Illinois, that we were best buds in 8th grade. And we both wanted to be physicians. And so we pushed each other. Academically, we strove to do our best. I remember we used to sign out to, like A or A+. How do we do on the test? We'd do sign language across the class. We were encouraging each other to do our best. But just having a friend who was on that path as well, I think was really helpful. Just knowing I wasn't doing it by myself. I mean, we went to different schools, but I appreciate her. Those are probably the two that I could think of the most.
Oh, wonderful.
Yeah. Just, mom saying I could do whatever it is I wanted to do.
Perfect.
Well, thank goodness she said that, because now here you are. And I think you're going to help so many people. So
perfect example of medicine meets compassion in the fullest sense. Awesome. Beautiful. Appreciate you, what you're doing.
Well, thank you. Thanks for letting me share my story.
Gosh, of course. And you can follow us on Spotify, iHeart, Apple Podcast, and then you can watch this episode on YouTube. Also listen to it as well. So thank you so much for joining us today.
Thanks again for the invitation. I enjoyed it.
Thank you.
Thank you.
Thanks, you guys.
Love ya.
Love you.